Well, very good afternoon, and I would like to call on stage the eminent speakers for this very interesting instruction course, which is the real-world applications of corneal diagnostics, a case-based approach. Dr. Ishimoon, I would like to just request you to be on stage for this. Thank you, sir. So, my name is Dr. Amit Gupta. I am from the Advanced Eye Center at PGI Chandigarh, and along with me, we have very experienced speakers for this session. Professor Arun Jain, who is also from the Advanced Eye Center, PGI Chandigarh. Professor Chintan Malhotra, who is also with us at PGI Chandigarh. We have with us Dr. Samar Basak, who is from the Drishti Eye Institute from Kolkata. And we have Dr. Rishi Mohan, who is from the Eye Tech Institute in New Delhi. So they are all very, very experienced with all the technologies that they'll be talking about. We all understand that it's our job to make the life of our patients better, to make the results of our surgery also more predictable and more efficient so that our patients can be satisfied at the end of the day. And this course, hopefully, no matter whether you're a cataract corneal surgeon, but it's for every ophthalmologist that you'll gain something, what this technology means and how you can apply it on the patients. So, for just the overview of the course, the first talk will be by Professor Arun Jain, and he'll be talking about elevation-based tomography with the Pentacam AXL, expanding indications. Then I'll be talking about ray tracing aberrometry for corneal and lens-based refractive surgeries. Dr. Chintan will be talking about sept source OCT and applications for the anterior segment surgeon. Dr. Rishi Mohan will be talking about corneal biomechanics, need of the hour, and Dr. Samar Basak will be talking about tear film diagnostics, focusing on LipiView and LipiFlow. So, without further ado, I would like to invite Professor Arun Jain for the first talk, which is on Pentacam AXL. Dr. Jain, please. As Professor Jain is setting up his talk, can you please raise your hands? How many are using Pentacam? How many in the audience are using Pentacam? I know, so yes, only a few are using. And how many have access to anterior segment OCT for the anterior segment problems? Okay, that's very nice. That's very nice. That's good. Itrace, please. Itrace users. Okay, and LipiFlow and LipiView, 2 people. Okay, so I think these technologies are exciting, and whether you should invest in them, your time and money and effort, I think that will be clear after this instruction course. So, I'll be, Professor Jan will be setting up his talk on the other computer. There was some technical hitch. So, I'll proceed with my talk, which is on ray tracing aberrometry for corneal and lens-based refractive surgery. So, now this is what the Itrace looks like. And what is it? It is basically, it's a placido-based topography, and at the same time, there is an aberrometer, right? So, it provides us with auto-refraction, it provides us with the keratometry, placido-based corneal topography. It also does ray tracing aberrometry and does the pupillometry in these patients. So, what is the advantage of an Itrace? So, what it does is it fires 64 spots 4 times to gain 256 spots, right? And this is used to generate what is known as the retinal spot diagram or the point spread function in these patients. So, all the data, the quantitative and qualitative data that you are getting is derived from this retinal spot diagram and point spread function. And since the patient is looking at a target which is distant with the relaxed accommodation, the measurements and the values we get are a lot more physiological than with other machines. So, now just a word about other machines like the Hartmann-Shack aberrometer or Scherning aberrometer or the skioscopy based OPD scans. What they have is there is a fixed signal which goes into the eye and fixed signal which comes out. So, there are some inaccuracies which can come in, something known as the crossover effect can come, or there can be some duplication of spots. So, that can actually, especially in complicated eyes, it can lead to a problem in the data that you collect. What the ray tracing does is it fires individual spots and individually they are analyzed. So, therefore, the data which we get is far more accurate and it does not suffer from the inaccuracies of the data collected. Now, what all can the Itrace do for us? One, it can help us in the preoperative planning of the patient, okay, both for cataract and refractive surgery. And most important question, does the patient need cataract surgery? Patient comes to you, he has a 6/9 vision or 6/6 vision. Does he need cataract surgery? This can help you decide that. It can help us in diagnosing certain lenticular pathologies. It can help us in assessing the visual outcomes. It can help us in planning the toric IOLs. It can also help us in deciding whether the refractive complicated patient with residual error, does he need enhancement or can we just leave him alone? And most important, is this patient a good candidate for multifocal intraocular lenses? So, I'll just be going through them in the next 10 minutes or so. So, what program do we use to decide to do the preoperative planning? We use the topography, we use the aberrometry, right? So, it starts with the data verification. So, the good part about this machine is you can see how accurate is your data and how reliable is it to plan your surgery. So, a quick assessment can be done and at the same time it gives a nice overview. This is a tracy refraction which has been shown to be very accurate when compared to a manifest refraction and also gives us the RMS values of the higher order revisions of the eye. Next, we move on to something known as a wavefront display. Now, many of us, we don't want to go into figures. We just look at what is going on. So, when we look at this map, this is not a topography map, it is actually a map of the wavefronts. And this look gives us just a qualitative kind of a look. So, when we see these kind of colors, we know that there is something wrong with this eye and we should look more closely at this eye. And when we look at the Chang analysis, so one was the wavefront analysis, we have gone into the Chang analysis. So, this gives us a more quantitative. So, when we want to look closely at any of the errors, so what it does is it will automatically show up that these values are significant in these patients. So, this will quantitate the whole thing. So, this also helps us in planning the surgery of these patients. Now, does the patient need cataract surgery? So, this involves grading of the cataract and DLI. We know we rely on Lox grading. Lox grading is also, although you are comparing with photograph, it can be subjective at times and can have errors. So, look at this patient, 6/6, complaining of diplopia, dissatisfied with vision, even after glasses. What do you do with such a patient? So, this is not from this patient, but it shows us there is something known as an opacity grading. So, this opacity grading is generated in the Itrace. Now, this grades are, it may be 1 or 0, 2.5, 4, whatever it is. They say that if the value is more than 2.5, we can be reasonably certain that if we take out the cataract, this patient is going to be happy and he's going to see well after surgery. It's a very big thing when we are planning surgery in these patients. The something else that it gives us is known as dysfunctional lens index. So what is that? It is calculated based on, very complex formula, which is a secret by the company, higher order aberrations, visual acuity, contrast sensitivity. Basically, it's a numerical value which tells us of the visual performance of the lens. That's it. And so just imagine that you have a number which comes and okay, fine, is the lens possible that the lens is causing these problems? For example, in this patient is 2.97. So any DLI which is less than 5, 10 is 0, I mean absolutely normal vision. So less than 5 is considered to be visually significant. Then we move on to diagnosing lenticular pathologies and assessing visual outcomes in patients of surgery. So one, we have something known as a vision simulator. So patient comes to us, has a cataract. For the doctor also, it's so much easier to show this to the patient and say, listen, I understand your problem and probably this is what you're looking at. It's remarkably accurate, what it generates. So this is the kind of simulator that is available on the Itrace. So this patient was a 21-year-old lady who came for refractive surgery. Now we're just going to look at the Itrace map. So the corneal Itrace map is normal. It also gives something known as the internal or the lenticular maps. So this was hazy. And when we move on, we see, again, I'm going back to the Chang analysis. And Chang analysis shows us that this internal means probably something in the vitreous or the lens. So this internal means there was significant aberrations which were there, which were not associated with the cornea. Cornea showed a astigmatism, and we know that astigmatism we can correct with the refractive surgery. And sure enough, this patient had a lenticular coloboma. Again, just to revise, you can see the wavefront map. Cornea is all green, means normal. This is rainbow colors. Immediately as you look at it, you will realize that something is wrong with the lens. I need to take a close look at this patient. Even PCO, we will have to decide, does the patient need a YAG or not? We know that YAG capsulotomy can have a problem. We don't want to do it left, right and center in patients. And again, both the DLI becomes significant and both the simulation chart becomes significant. These patients, once we do a YAG capsulotomy, see perfectly well. Patients of scleral fixated IOLs, just a patient showing dissatisfied with vision, and just by doing the eye trace, we can see that the patient has a significant coma and patient had a lens tilt, which was causing the astigmatism. Toric IOLs, I'll not be going into detail because of the lack of time, but it does have a toric planning system, including the Zaldivar calipers, and even for misaligned toric IOLs, it's very good to help us to align the lens in the correct direction. Now, whether a patient needs an enhancement or not, this is something known as an MTF. So MTF is basically, it's again a numerical way of measuring the contrast sensitivity. We know how painful it is for the patient to measure the contrast sensitivity in a patient. Here, within 2 seconds, you are getting the reading. And what it shows is, if you see the red box, which corresponds to 40% of contrast versus 10 cycles per degree of the spatial frequency, any reading above this is considered to be okay, normal. And if it dips like that, it means it is there's something wrong with it. So in this patient post LASIK surgery, there was a little dip, and this patient was not satisfied. The patient underwent an enhancement of LASIK, and then this is the preoperative and this is the postoperative vision, and tracy refraction is almost normal. The aberrations were also within normal limits. So this is how the contrast or the modulation transfer function improved in this patient after surgery. So in the end, is the patient a good candidate for multifocal IOLs or not? So what it does is, the Itrace gives us angle kappa and alpha. Now kappa we know is visual axis to the pupillary center, and if it's too decentered, we know that he's not a good candidate for premium IOLs. And same with angle alpha, it's how well does the bag fit with respect to the pupil. And basically it's a visual axis to limbus. It's measured from the limbus, and it gives a very, so if it's more than 0.5, either of the values, you should be very cautious in planning multifocal surgery in this patient. So just a simple algorithm for IOL selection using Itrace. So perform the Itrace for multifocal IOLs I'm talking about. Perform the Itrace, assess angle alpha kappa. And if the kappa is more than 0.5, plan a multifocal IOL. If the kappa is less than 0.5, what we do is we look at the Chang analysis. Now, we consider corneal aberrations of 0.14 or more or less to be significant. So, if it is corneal aberrations are more than 0.14, we should go for monofocal IOL. And if it is less than 0.14, we can plan for either toric, multifocal or other premium IOLs like enhanced monofocal lenses. So it also gives us an IOL selection analysis. If you really don't want to remember too many figures or something like that, it just gives us this little box here. And you can see in this box, is the tracy refraction normal? Yes or no? Are the corneal higher order aberrations present? No. And internal aberration, higher order aberrations present? Yes. This is because of cataract. And if the cornea is not abnormal, it recommends that you can go in for a premium intraocular lens in this patient. So just to conclude, a 2020 unhappy patient is unacceptable in the 21st century. And then in this new era of cataract and refractive surgery, I think the Itrace is an invaluable tool, not only in the surgical planning, but also in communicating, teaching the patient what is there. We understand his problem. Most of the patients are very satisfied to see, yes, they come with diplopia, although they have a cataract. There was a patient who was advised a CT scan, but just had a cataract, and we diagnosed it with also aided by the Itrace. And it also helps us to understand the outcomes of surgery better. Thank you very much. I can take a question as long as till Dr. Jain is setting up the. Dr. Rishi Mohan will be talking about corneal biomechanics as he has to go somewhere. So we'll have his talk next.
अभी ठीक है, but ऋषि now wants to present first. He has to go. वो FPS का.
I would be happy to take any questions till Dr. Rishi Mohan is getting underway. How many plan to buy the Itrace after this talk?
Itrace is a beautiful device. You use it for all your cataract patients now, without exception, or only for the premium?
Sir, although it puts a lot of load on the cornea lab to be doing it for each and every person, but especially for all premium IOL patients, now we are putting in a lot of enhanced monofocal lenses and all that. That's a must, I think, and actually it should be done for every cataract patient, no doubt. Every refractive patient definitely gets it done.
So I think what is probably going to happen with time is that these technologies are going to gradually become what we call standard of care. It will take a while before devices like the Itrace or even devices like what I'm going to speak of on corneal biomechanics will find their way into every clinic. But we can already see how OCT has penetrated into a deeper segment and how the Scheimpflug based systems will also come in. So I think it's a healthy trend in that sense.
Correct.
So are there any questions for?
So we can take them in the end.
All right, then shall I
yes,
proceed?
yes, sir. Yes, sir.
So thank you very much, Dr. Amit, to invite me to this course, and I thank the AIOC for this opportunity. So I'm going to speak about a subject that I've actually spoken of for the last, 10, 15 years now, and trying to build up the understanding of corneal biomechanics amongst the ophthalmologists and how important it has become. And actually, if you look at corneal biomechanics, it actually, during our residencies, we all heard about the outflow facility and we heard about scleral rigidity. However, we never had a very good means or a technology which could actually capture it. So the tonometry studies done 40, 50 years ago were really the base for the production of these equipments. So these have now gained importance because of the advent of refractive surgery and the complications that arose out of it, namely ectasia. And it is impossible still to measure corneal properties such as hyperelasticity, hysteresis and viscoelasticity in vivo, but these instruments at least are a step in that direction. And it's possible to better plan refractive procedures that result in these unexpected aberrations, and it also possesses the ability to eliminate the effect of corneal stiffness on intraocular pressure measurements, and I'll elaborate this as we go on. So it's important to understand what we mean when we use the term viscoelastic. So basically, think of a shock absorber. A shock absorber contains two components really, a component in which there is a spring, and there's another component in which there is a gas or a fluid-filled viscous container in which a piston kind of thing goes in. Now these two have different components to how they handle tension and pressures. So the spring is what we call an elastic part of the system, where the deformation, or when you pull or push a spring, it is directly proportional to the stress that you apply. So if you apply more force, you'll get more deformation. You apply less force, you'll get less deformation. And this is independent of the length of time at which you apply it or the rate at which you apply it. So the rate of application of force or the length of time at which you apply it is not relevant to the amount of deformation that you will produce. On the other hand, viscous resistance or damping, which is the shock absorbing effect, is directly dependent on the speed with which it is applied. So the harder you try and push a piston, or the faster you try and push a piston into this cylinder filled with gas, the more resistance you're going to encounter. So this is the combination of viscous damping and elastic properties that creates the unique structure of the cornea and the sclera. Now let's talk about the Goldman Tonometer. Fantastic device, but it makes static adjustments or static assessments. So what does it do? It takes the cornea and it applanates it. Then it gets into a steady state. And when it's in a steady state, it takes a reading. This derives the intraocular pressure. But the ocular response analyzer, which is the instrument I have largely worked with, and now the Corvis ST, which is the newer kid on the block, these make dynamic measurements. So what do? They throw an air puff like a standard non-contact tonometer. However, they are monitoring the movement of the cornea throughout the length of the air puff. And this dynamic measurement allows the possibility to capture the data. So this is what happens with a standard conventional non-contact tonometer. A force hits the air pulse hits the cornea, and as the air pulse increases, it reaches applanation. And the moment it reaches applanation, the machine shuts off. That's what standard NCTs do. And at the point of applanation, whatever was the force being implanted or imparted to the cornea is measured as the pressure, same like a Goldman tonometer. However, with this instrument, I'll come to this graph later, if you look at the charts at the bottom, you will realize that this air puff first creates an initial applanation pressure where the flattening happens, but then this continues to create a concavity in the cornea, and then it starts to come down, and when it starts to come down, there is a second applanation that happens on the out phase of the corneal pressure, and this creates applanation pressure too. And then, of course, the cornea comes back to its normal convex shape, but in this process, the cornea also shows some rebound or flutter, and because it's a viscoelastic equipment, so that entire thing is monitored by these machines, and lots of data is able to derive from it. But broadly speaking, the single most important data that one gets is the difference between applanation pressure 1 and applanation pressure 2, and this is called corneal hysteresis. So studies have concluded that the variation in corneal thickness affects the accuracy of the measured pressure. However, the over or underestimation of pressure caused by corneal interference is only valid on average, and the relationship is not very significant. And if you talk to glaucoma opinion leaders, they'll tell you that adjusting intraocular pressures just by using a thickness-based algorithm is essentially flawed because of the fact that the thickness and the viscoelastic properties of the cornea don't correlate. So look at this. This is the corneal hysteresis and the corneal thickness. The R value is 0.27. So you can see that the corneal thickness can vary from 450 microns to 650 microns, and the scatter of the of the amount of hysteresis that there is all over the place. So there is no distinct correlate between thickness and the way this cornea actually behaves when you try and subject it to any pressure. And this is the problem with these corneal, the CCT-based IOP adjustments. So you imagine a piece of pine wood and you try and put a force in it to bend it, and then you do the same thing with the same thickness of oak wood, and you'll realize that the same force does not cause any distortion at all. So thickness is not resistance. And this is what happens in people with normal tension glaucoma. Are these patients really normal tension? They have glaucoma, but do they have a normal tension? The answer to that is they probably don't. They're probably glaucomas with a high pressure, but they are being missed because the machine is giving you a normal tension. And that is why machines that allow you to give what we call an IOP-CC. IOP-CC stands for intraocular pressure corrected for cornea. And IOP-G is intraocular pressure by Goldman. And this is the kind of graph that you will see. All these patients of NTG were actually, actual pressures were much higher when the IOP-CCs were measured rather than when IOP-G. So IOP-CC measures higher than current tonometers in NTG eyes. Again, in post-LASIK, we've thinned these corneas. What happens to your Goldman pressures? They drop. On average, they will drop 26%. But if you look at the IOP-CCs, they only drop 3%. That's because they are not looking at the thickness at all. They're looking at the biomechanics of this machine. So the IOP-CC and Goldman on average will correlate, but will not be affected by CCT and will not be affected by corneal biomechanical properties, and therefore is far more accurate in keratoconus, in Fuchs, in ocular hypertension, in normal tension glaucoma, and it has much less influence by doing a post-refractive procedure, and there is of course no operator bias. So thickness, as I said, is not strength, and that is the problem with refractive surgery. We look at thickness, we have this PTA formula, and we have a formula of residual stromal bed. All these are flawed, essentially because they may be soft corneas, which may require larger residual beds, and that's why you hear of the patients who followed all the norms and still went into ectasia. And those which may have hard corneas, and we all have experience with patients who we, in the earlier days, did very high numbers of ablations and still got away with it because they can take these aggressive ablations more safely. So the pre and post LASIK, if you look at the hysteresis values, you'll find that there is the average pre-LASIK population has a higher hysteresis than the post LASIK population because of the thinning that has been produced. But they may be the outlier, and that's the patient that you need to look out for because he's the one who's prone to develop ectasia. Similarly, when you classify corneal pathologies, you have patients with keratoconus on one hand, which are thin corneas, and you have patients with Fuchs dystrophy who have thick corneas. So the thickness can vary by 100 microns, but they all have less than normal hysteresis. So thickness doesn't necessarily relate to how the cornea actually behaves biomechanically. And these are some of the analysis of the normal signals from these machines, where those who are familiar with these signals will immediately know what I'm talking about. These are nice similar signal amplitudes of the first graph that I showed you, the applanation in and the applanation out. The CH and the CRF, as well as the IOP-G and IOP-CC are in the normal range. But when you look at keratoconus, you see blunting, you see a noisier signal, you see lower amplitude in the peaks, which are sharper and thinner, and you get a bounce because of the flutter of the cornea as it settles down. It doesn't just settle down like a rigid structure, it flutters as it settles down, and that's what is picked up by these equipments. So subclinical keratoconus again has been classified by these machines. Severe keratoconus, look at this. The cornea is so soft that when the corneal pressure, when the air puff hits, the whole cornea just flattens. And that's why there is hardly any result or any signal coming back from the cornea. So pre and post LASIK signals similarly are very similar, but the IOP-CC is higher than the IOP-G, again because of the fact that the cornea has been thinned. And there is the little bit of noise and P2 bounce. Ectasia starts to behave like keratoconus. So if you have a patient of ectasia and you're not sure, put him onto one of these ORA machines and it'll give you a diagnosis immediately. So there's another part of this thing called the Keratoconus match index, wherein one can put the patient on this machine, and based on the corneal biomechanical values, it can suggest what is the possibility that this patient has keratoconus. So this patient, for example, 89% chances are he's normal. This patient, only 34% chances he's normal, 53% chances are that he's a suspect. And this patient has mild keratoconus, possibly 26% chance he has a moderate keratoconus. So these are the kind of things that are there. Post cross-linking, a little bit of improvement is seen, which is not dramatic. So the signals are the corneal signature in this machine, and that is something that is of great value. And these are the clinical applications for corneal biomechanics in pathology diagnosis, ectasia screening, post-LASIK IOP measurement, much better to check the post-op corneal stability and wound healing, the glaucoma diagnosis, normal tension glaucomas and ocular hypertension sleevings, and also glaucoma treatment efficacy. The latest kid on the block, the last couple of slides, is the Corvis ST. And now the beauty of this machine is that it has now been clubbed with the Pentacam. So you can now get a combination of the two, which gives you topographic values, thickness values, and now biomechanic values, and they've all been clubbed together to make it easier for people like me to understand. So this again works on the similar principle, except that instead of optical assessment devices, it actually has a shine flow camera and can give you a video of that corneal fluttering as what I explained to you in the beginning. And then it also gives you a biomechanically corrected IOP, which is called the BIOP, similar to the IOP-CC that I spoke of. It gives you a biomechanical index, and it gives you, with the tomography, if you club them together, something called the tomographic biomechanical index and the biomechanical glaucoma factor as well. So these are some of the new things that have come out. And just to highlight a patient who was finally changed in terms of what we were planning to do, was a patient who had moderate myopia, normal Ks, not a very thin cornea. An initial plan was to do a femto-LASIK, but then after looking at the biomechanics and looking at this, and you can see at the bottom there, the circle where that line is in the red zone, so the tomographic biomechanical index of this patient wasn't very good. So he was taken off the LASIK list, put onto a PRK, and also an extra procedure, which means the CXL was done simultaneously. So to summarize, the biomechanics assessment is now a major investigational modality. Ectasia detection and filling the missing link in the screening is important for high-risk refractive surgery cases. It assists proper IOP evaluation and the detection and management of LTG. And tonometers equipped with biomechanical adjustment algorithms are more accurate in diseased corneas and in post-refractive cases. And they allow in vivo measurements of corneal biomechanics can be used to assess the efficacy of corneal cross-linking and corneal healing. So thank you so much. I'll be very happy to take any questions. Thanks, Amit.
Thank you so much, Dr. Rishi. Dr. Rishi Mohan has, very nicely brought forth the role of corneal biomechanics. A lot of us are reluctant to do it. We do not really want. I have one question for Dr. Rishi, that we do it in so many patients before refractive surgery. And do you repeat it after refractive surgery in these patients? And if so, after how long in patients who have had thin corneas, they've undergone LASIK, just as to record something that, that, okay, fine, this is how it was.
No, actually, that would, I think in busy practices, people would hardly do that. So if it's an uncomplicated refractive surgery, he's had no problems, he's doing well, we wouldn't ordinarily put him back on this unless we suspect that his IOP was borderline, or if he has a large disc, or if he was a very high myope, and you still want to see what his corrected pressures are, because his pressures will, like I said, substantially drop if you put him on an applanation tonometer or if you have a conventional NCT, because the conventional NCTs are all calibrated according to IOP Goldman. They are not looking at corneal biomechanics at all. And so 90% of the tonometers which are currently out there are not catering to that. So that where this scores hugely.
So any questions from the panel or from the audience? We move on to the next talk, which is by Professor Arun Jain, and this is dealing with the corneal tomography with regard to the Pentacam AXL. Professor Jain, please.
Thank you, Amit, for giving the opportunity and putting together this nice instruction course on diagnostics. So I'll be talking about elevation-based tomography with Pentacam AXL. There are a lot of indications or there are a lot of problems where the Pentacam can be used, but I will be mainly restricting myself to the corneal problems and calculation of IL power in post-refractive surgery. I have no financial interest in the subject matter of this talk. And as we all know, there are a lot of instruments available which can give us corneal topography. Many of them are slit scanning and elevation based tomography. We have rotating Scheimpflug principle, and in that we have again a series of instruments, but I'll be giving my talk based on Pentacam only. And these are the various conditions for which Pentacam has been being used. Most common is screening for refractive surgery to rule out keratoconus or ectasia or progression of keratoconus, especially subclinical keratoconus, and also it has applications in planning phakic IOLs and intracorneal rings, and in cataract surgery, lens densitometry for knowing the hardness of the cataract, as well as post-refractive surgery IOL power calculations and choice of IOL, which type of aspheric or toric IOL we can choose based on the Pentacam findings. So there are a lot of applications even in glaucoma. So I will be restricting myself only to these three: screening for refractive surgery and post-refractive IOL calculation and choice of aspheric IOL. So coming to the first topic of keratoconus screening. So there are various maps on this Pentacam. On an anterior elevation map, you have to look for any elevation more than 12 micron is considered significant. Any value more than less than 12 micron is considered normal, but more than 15 micron in central 5 millimeter area in the best fit toric ellipsoid map are typically indicative of keratoconus. Similar number which are about 5 micron more on the posterior surface are taken as significant. These values are significant only if present in central or paracentral area in a localized pattern. High plus value may be seen in periphery because of astigmatism, and they do not denote abnormality. So abnormal elevation is present can be present in an R-line pattern on the anterior as well as posterior surface. So this is the anterior surface and this is elevation front. This is the sagittal map. So they can be present on anterior as well as posterior surface, and it can also be in the form of tongue-shaped projection rather than, because as the keratoconus progresses, this island separates and it becomes an island, and this is again in the form of island. And this is the representative patient who had a -2 Dr spherical refractive error, and they came for LASIK surgery. Pachymetry is 560 micron, which is within normal limit. There is little asymmetrical bow tie on sagittal map, but you can see the elevation on back side is to the tune of 20 micron, which is significant. And this is the other eye of the same patient, where you can see this is the left eye and this is the right eye. There is an anterior map, sagittal map shows a K reading of 58, and there is an elevation, front elevation of plus 36 micron, and posterior elevation is much more, so more than 20. So this is a overt case of keratoconus, but sometime when the findings are subtle, we have to look at the Berlin embryosa enhanced ectasia display and the comprehensive pachymetric progression. So this is an example just to show that this is a patient who had a 460 around micron thin corneas. And what in this Berlin-Ambrosia map does is a 3.5 millimeter optic zone centered on the thinnest point in the is excluded from the reference shape map. So you get a reference map like this, and creating a new reference surface has minimal effect on the normal cornea, but it greatly enhances the ectatic cornea or irregular cornea. So if you see here, these values are on anterior and posterior surface elevation, and this is on Berlin-Ambrosia map. So it enhances the elevation both on anterior and posterior surface. So this is called Berlin-Ambrosia display map, and this is very sensitive screening tool for keratoconus suspect or firm frost keratoconus, and also patients who come for refractive surgery. And so this is another patient which has what to look for on this enhanced Berlin-Ambrosia map. So you have these value also. These are the elevation. These are these value 5 values are when they are in white, they are within 1.6 standard deviation. When they are displayed in yellow, they are more than 1.6 standard deviation, and red means they are significant more than 2.6 standard deviation. And the overall D value, which is more important than the individual value, if it displays in red, and even if these elevations are not there, then one should not proceed on to do a surgery. And there are 9 important parameters on this map we should be looking for. 5 of these are these values, which is DT is anterior elevation change, DB is posterior elevation change, this one, and DP is pachymetric progression, DT is thinnest point pachymetry, and DY is displacement of thinnest point from the apex. And here you get a artmax. The cutoff value is 339 micron, and other values of anterior and posterior elevation and Kmax. These are the important things to be looked for in the Berlin-Ambrosia map, and in this case the overall D value is around 11.48, which is significant, and the pachymetric progression index is normally is around 0.12, but here it's 0.64, and artmax is 1.26, which is less than the normal one. So this is a overt case of keratoconus. And this is another map, Holiday report map, which is a best fit toric ellipsoid map. And if in this map, this is tangential map, anterior surface, this is pachymetry, and this is elevation map on the back surface. If the hot spot on tangential curvature, this is the hot spot, elevation, and the relative pachymetry, thinnest pachymetry, as well as posterior elevation, if these 3 points coincide, then it is diagnostic for keratoconus. So this is more important than overt keratoconus, because many of the cases which come for refractive surgery, they may have subclinical keratoconus, which is defined as a state, a premature form of disease in which characteristic keratometric, retinoscopic or slit lamp findings of keratoconus are absent, but there are only mild topographic changes which are consistent with clinical keratoconus, and they have a potential to develop ectasia after the surgery if we are not careful about diagnosing. This is a representative case which has a very high K rating, more than 47, and it can, as you can see, the pentacamera itself says it is abnormal, this is not within the normal range, and even the one of the indices is shown in red, and you can see the pachymetry is thinner, but there is no asymmetrical bow tie, there is no elevation on anterior and posterior map. Pachymetric progression is normal, but once you go to a bad map, the pachymetric progression is in yellow area, so one has to be careful, as well as the D value is also more than 1.6 standard deviation. So you should wait and watch and take a family history. If the patient has a family history of keratoconus, you should avoid doing surgery in these cases. This is the other eye of the same patient. Here you can see the pachymetric progression is in red, and D value is 2.18. So you should avoid doing refractive surgery in these cases. Coming to IOL power calculation in post refractive surgery patients, if you don't have a pentagram, you don't have to worry. You can go online. There are ACRS website as well as APACRS, where you can have all these online calculators. But you can also have the tomography. This pentacam gives us equivalent K reading, which is based on true measurement of anterior and posterior corneal surfaces, and based on the true refractive index of cornea, which is 1.376, and based on this we get this EKR map, and the EKR value in the central 2 to 4 millimeter of cornea, they are normal, but Savani et al. Has shown that we should be using 1 to 2 millimeter reading of EKR rather than 4.5 millimeter. They are more accurate in calculating the IOL power. This is a patient with post-radial keratotomy with the diminished vision, and 8 RK scars were there. So patient wanted surgery, and this is the biometry of the eye, and these are SIMK reading, and but EKR readings are around 34.7, on an average around 35 at 1, 2, 3, 4 millimeter. And this is the pentacam holiday report of this patient, and you can see the EKR value, and taking into account the EKR value and calculating the IOL power using the SIMK, we could have chosen this lens, okay, because on SIMKs were higher, but EKR values are lesser because there is a fallacy in calculation of SIMK. So targeting a myopia of this, we used a lens of 19 diopter in this case, and we ended up post-operative reduction of 1.5 cell. But if we had chosen a lesser power, we would have ended hyperopic in this case. And then using this pentacam for choosing neutralizing spherical aberration in cornea. As we all know, as the age advances, the negative spherical aberration of the crystalline lens also become positive, and it adds to the corneal aberration. And we should be using, depending upon the status of the patient, if a patient has undergone hyperopic LASIK, they have increased positive spherical aberration, so we should have we should be using either a traditional IOL or wavefront with positive spherical aberration. Post myopic surgery, the negative asphericity positive asphericity increases, so we should be using negatively aspheric IOL, and where the any chance of subluxation or descentation, we should be using aspheric neutral lenses. This is a cataract surgery planning map. In this map, if you look here, this gives us the total spherical aberration at 6 millimeter zone. So normal is around 0.27 micron. So depending upon that, one can choose a spherical IOL, and different IOL have different magnitude of asphericity. And as you can see, these are the two eye of same patient. In one eye there is a normal IOL, but in other eye there is a negative aspheric. You can see the spheral ratio is close to 1, and the point spread function is also very good. So pentacam helps us to in choosing different types of aspheric IOL or non-aspheric IOL depending upon the asphericity of the cornea. And here you can see again in one eye there is a normal lens, 80 lens, in other eye IQ. You can see the point spread function also very good in this case. So so these are also called wavefront corrected IOLs. So I think that's the that's the end of the talk. There was okay. I think I should stop here. So I have covered. Yeah. Thank you.
Well, Thank you, sir, for an excellent talk on Pentacam and what it can do for us. Any questions from the audience? We can take one question from the audience or any comments from the panel. So when you're planning a toric intraocular lens, cataract surgery, do you think that Pentacam, looking at it, is a must? Or you just rely on sometimes on biometry, like it tells you?
Yeah, so once we are doing a toric intraocular lens, first of all, we have to be sure that the axis and the magnitude of the toricity. So we should sort of confirm that on at least two instruments. One is the IL master, and then you have the choice of either Pentacam or any other instrument. But the advantage of Pentacam is it gives us also the posterior corneal astigmatism. The IL master 700 also gives us a combination of total K. So total K is very important because posterior corneal astigmatism also accounts for the toricity or the refractive astigmatism. Though there are in Barrett's toric, it's presumed, but the actual amount of toricity, because the rule is if it is with the rule astigmatism, we undercorrect it, and against the rule astigmatism, we overcorrect it because the toricity on the posterior surface is like that. But Pentacam will tell you exactly this amount of posterior toricity. So it is more accurate as compared to other devices which doesn't measure the posterior corneal astigmatism.
Thank you so much. And we go on to Dr. Chintan, and she will be talking about anti-segment OCT and swept source anti-segment OCT, and what are the applications for the anti-segment surgeon.
Thank you, Dr. Amit, and thank you to AIOS for this opportunity, and a very good afternoon to all of you. My topic is swept source ASOCT applications for the anterior segment surgeon. At the very beginning, I would like to give a disclaimer that the swept source OCT is used, it has its uses both preoperatively and intraoperatively as well as in biometry. What my talk will be focusing on mainly is the preoperative uses of the ASOCT, because the intraop use of the swept source OCT opens up a completely different dimension, as does the biometry. Time permitting, I will speak a little bit about biometry, otherwise it's mainly about the preoperative. Also, swept source OCT is something which is used not only by the anterior segment in terms of cornea refractive surgeons, but also by the glaucoma surgeons, by the squint surgeons, because it helps to see all these structures so well. But this talk will be mainly about the cornea and refractive. So as we understand, we need to understand the evolution of the OCT systems, and the OCT systems have evolved from the time domain, which had a greater penetration and a depth of imaging. So you could see a wider area, but consequently they had a lower axial resolution. This was followed by the spectral domain OCT, which are still very much in use. These have a lower wavelength, and hence they have a limited scan depth and a limited width. But the advantage of this is that they have a better axial resolution. And then we have the ideal combination of the two, where we have the swept source, which uses a longer wavelength, and it has a scanning tunable laser, which combines a greater scan depth and the width with a fairly good axial resolution of around 10 microns and very high scan speeds. So that again is very important, because it can be used in uncooperative patients, children, because the speed of acquisition is so fast. And additionally, like I mentioned, some of the swept source OCT systems like the IOL Master 700 and the Antirion are also used for biometry. So this is just an example for, we see the pictures with the anterior segment module of the Spectralis, which is a spectral domain OCT. If we want to see, let's say, for example, an ICL, we want to see the angle, then we have to sacrifice the cornea. If we want to see the cornea, we have to sacrifice the angle. On the other hand, with the swept source OCT, you can see right from limbus to limbus the angle, as well as up to the posterior surface of the lens. So swept source OCT allows for a wider and deeper scan and includes the entire lens, including up to the posterior capsule. Now, applications of ASOCT, my first few slides are not of the swept source OCT, but I think it's also important to know the other uses. These are of the spectral domain OCT. So ASOCT basically provides us an optical biopsy. For example, if we have two patients who have similar looking lesions at the limbus, we want to know, at least have a clue what they could be, apart from our clinical clues. In the image on top, we see that the lesion appears to be arising subepithelially. The red line is tracing the epithelium. It's arising from below that and pushing the epithelium up. So we know that it's not likely to be a tumor arising from the epithelium. And this on histopathology proved to be a melanoma. On the other hand, the image at the bottom seems to be continuing from the epithelium and then going up. The lower tissues appear normal. And this on histopathology was a OSSN. So it just gives us a clue as to what the lesions could be. Then we can monitor the resolution of the lesions. For example, in this case, after 3 cycles of mitomycin C, there was complete resolution. We saw hyporeflective epithelium. In another case, there was residual disease even after treatment. We see the hyperreflective epithelium, very thin layer shown by the yellow arrows, and so topical interferon treatment was continued for a while. ASOCT, whether it is swept source or spectral domain or time domain for that matter, helps in surgical planning of corneal pathologies. For example, if you have anterior any of the dystrophies, you know what depth to go at. You can plan your surgery accordingly, and then one can have gratifying visual outcomes. In cases of keratoconus, you can see what is the level of scarring. If the scarring involves the descemet membrane, you don't want to go in for a DALC, or at least you don't want to go in for a big bubble DALC. In this case, it was showing the epithelial scarring was subepithelial, so one can happily go ahead with a DALC as well as plan a big bubble DALC. In case one is not able to achieve a big bubble, it also can show you your post-operative. You can see how much was the interface left. For example, in this case, we were not able to get a big bubble and very minimal interface left. And the other uses are, of course, for endothelial keratoplasties. Again, in the intraoperative, of course, we have for the DMEX and the DSEX to see their orientation. But that's, like I said, another whole universe itself. Then one can see the depth of the demarcation lines in CXL to see what are how effective the CXL is. And then you can use it to see the LASIK flaps. What was your thickness of the LASIK flap in case of patients who need retreatments. So once all the other OCTs give us, the spectral domain gives us all this, what's the added advantage of a swept source OCT? I think this case beautifully illustrates this. This was a 70-year-old male who was referred with post-op non-resolving corneal edema after phacoemulsification. Now one could have different differential diagnosis, hard cataract, descemet membrane detachment, and so the first thing one would like to do if one cannot see anything on a slit lamp is rule out a descemet membrane detachment. An ASOCT done on a spectral domain machine shows you corneal edema. There is no descemet membrane detachment, and this is what one of our fellows came back and said, ma'am, there is no descemet membrane detachment, right? But the swept source OCT, because of its ability to image deeper, picked up the DMD which was missed on the spectral domain OCT. Now this will be seen in very few cases, but there are these cases where the decemets, the AC was deep and the decimet was far back, and here the swept source OCT, because of its greater depth, helped to pick up this lesion. And one can see that post-338 injection, one can see a much clearer cornea. So it helped guide us to the correct treatment rather than going here and there. But what the swept source OCT has dramatically changed is the management of lenticular disorders, basically, because the lens was not visible with the time domain or the spectral domain OCTs. So in white cataracts, posterior polar cataracts, traumatic cataracts, phakic lenses, we can see the status of the capsule as well as see the contour of the capsule, which is important in various cases. So coming to white cataracts, there are multiple publications, if you see, on white cataracts of both the intraoperative as well as the preoperative uses of the swept source OCT. And where I personally use it is that you can modify the technique based on the presence or the absence of fluid and the size of the nucleus, which sometimes may be difficult to determine clinically, as well as the status of the posterior capsule. So 3 examples to show this. This is a case with a white cataract. Your OCT shows you no fluid, there's a compact nucleus, your posterior capsule is intact, and additionally there's no posterior polar plaque. So one can happily go ahead and do a single stage forceps or a needle cystotome capsular excis as per the surgeon's comfort, and usually one would not anticipate any problems intraoperatively. On the other hand, this is an intumescent cataract with lots of intralenticular pockets which are close to the surface. And here, a simple needle aspiration with a 30-gauge needle to draw out the fluid and reduce the intralenticular pressure would help to reduce the risk of a rhinorrhexis very much, and after that one can go ahead and do a capsulorhexis. On the other hand, there are cases like this. For this example, this was a 30-year-old female referred with as a case of Fuchs heterochromic uveitis with cataract, and one can see that this cataract is completely like a football. There is very little fluid, at least near the surface, and basically it's all the cortical fibers which are separated. So these are the white cataracts which are at the highest risk of developing an Argentinian flag sign the moment you touch the anterior capsule. And this is where it's critical to use a very good quality viscoelastic device, and also a forceps-assisted two-stage CCC should be required, where you go in with the smaller rhexis, aspirate a little bit, and then enlarge the rhexis. These findings have also been beautifully shown in a publication by Dr. Tityal and colleagues, where they've shown the intraoperative dynamics of white cataracts. These cataracts have been classified and into 4 types. And here also it's been shown that the type 2, where you had the convex anterior capsule with continuous hyperreflective bands of swollen cortical fibers and intralenticular clefts which were below the surface, these are the ones which are at the highest risk of Argentinian flag sign, because here you can't really aspirate anything. So that's about the white cataracts. Coming next to the posterior polar cataracts. So there are again lots of publications in recent years, in the latest years, but the ones I liked most were the ones in 2014. This was the initial publication where they have graded cataracts, the posterior polar, depending on whether there was a clear space between the posterior polar plaque and the capsule. So if there was no clear space, the type 2 and the type 3 especially, those were at a much higher risk of an incidence of PCR. This was correlated intraoperatively with the preoperative pictures. So this is a case which was one of our, the fathers of our resident only, who I just operated before coming here. So this is a posterior polar cataract. This is a thick plaque. One can see it's a thick plaque. It's a large plaque, but one can make out the contour of the posterior capsule nicely. So one knows that it's a large plaque, but there is no defect, or there's no pre-existing defect. So one can, with caution, go ahead and not expect too many intraoperative problems. The other interesting publication on this was that it was correlated that the swept source OCT, if you do it preoperatively, it had a sensitivity of 100%, which means if a pre-existing PCR was detected, it was actually present in all cases intraoperatively. The negative predictive value was also 100%. So if the SSOCT does not show pre-existing PC defect, it's not likely to be present. It may overdiagnose in some cases where actually it said that there would be a PCR, but intraoperatively there was not, which is why the specificity is 97%. The other important role is in the use of traumatic cataracts. This is a case of a 32-year-old male. This is not exactly trauma, but a representative case. He had uveitis for 2 years, and there was a history of receiving intravitreal steroids. The patient was referred for a white cataract, and it makes you wonder whether it's the steroids or just anything else. And one can see on the SSOCT the beautiful way the breach is seen, and that just helps you to manage the case better. And so traumatic cataracts, UBM is also often used in traumatic cataracts where one cannot see the posterior capsule, but the SSOCT is less dependent on operator skill, and it has better cooperation in children, like I already mentioned. And the last topic is the phakic IOLs, where you can see the vault height with the phakic IOLs. One can change the size of the ICL in the other eye depending on the vault you get in one eye. The CASIA 2, which we have, which is the one I have experience with, also gives you an Icl Sizing Software. So there are 2 formulas in it which help to guide you as to what the size vault of the ICL you could take. Of course, these companies always recommend a manual measurement, but if you go retrospectively, you can see that in a lot of cases, it does correlate with that. And they've come up with a newer version which has a better predictability. And the last thing which I mentioned, swept source OCTs are used for biometry. The IOL Master 700, the anterior on the Argos. These are supposed to be much more predictable because they measure the posterior cornea as well. They can show you the lens tilt because it is an OCT. Fixation can be checked, and it penetrates dense cataracts much better than your other biometers, which were partial coherence interferometry based. So to conclude, SSOCT provides a greater depth of penetration and a larger field of view. The visualization of lenticular pathologies has greatly changed, and so has the management. And if available, SSOT should become a part of the routine workup for white, traumatic, and posterior polar cataracts, and as well as for biometry wherever possible. Thank you so much.
Well, thank you, Dr. Chintan. That was a lovely talk, and I think everybody enjoyed it. And we can take a question as Dr. Basak sets up his presentation. Any questions? I mean, so important thing is that, you know, where we think of step source OCT just for some tumors and other problems, but it has been beautifully demonstrated that it should be, in fact, almost, I think in future, once it becomes more affordable, will become a routine for posterior polar cataracts, intumescent cataracts, and they go such a long way in helping us in the whole thing. So we can take any other questions in the end. You can pass it on to me, or maybe if the time permits. Dr. Basak is there for the last talk, and he will be talking primarily on LipiFlow and LipiView, because there are too many regarding the tear film abnormalities and tear film diagnostics. So I have requested him to just focus on LipiView and LipiFlow. Dr. Basak, please.
Thank you, Amit, and I must congratulate Chintan for these wonderful photographs. I mean, mind-blowing all this. Your whole clinics will change after CASIA 2. This is wonderful, and thank you, Amit, for once again that beautiful and good audience is there. So I'll be talking on tear film diagnostic, mainly on LipiView and LipiFlow. I do not have any financial interest in this presentation. So if you go to the dry eye and MGD prevalence, this is the global prevalence of dry eyes. It varies from 8 to 30%, whereas MGD is between 38 to 68%. And you see that more in Asian population cohort than with Caucasians. If you see the Indian data, there are only 2 or 3 reports are there. One is from our center where the MGD is 37%, whereas dry eye disease is 32%, and one is from northern India where the prevalence is around 40%. So MGD is in the community, especially with aging population. And there are many studies of prevalence of meibomian gland dysfunction at the time of cataract surgery. 52% patient is having MGD, and 56% had meibomian gland atrophy, but 50% of the patient of the MGD, they are asymptomatic patient. This was published in 2018 in JCRS. So there is a direct correlation between cataract surgery and MGD, vice versa. So cataract surgery can worsen MGD, dry eye symptoms, whereas MGD, dry eye complex causes poor and unsatisfied outcome of cataract surgery. So it is both way, it is important. So there are several mechanisms during surgery, and we all know that frequent fluid irrigation, eye drop, phototoxicity, surgical trauma, incisional nerve damage, all lead to actually ocular surface trauma and increasing the dry eye diseases. And if you see that influence of cataract surgery on meibomian gland dysfunction, the study has shown that alteration of meibomian gland expressibility and TBUT persist for up to 3 months. So most of our patients come back and they say the repeated symptom that eyes burning, itching, sometimes watering. So direct role of cataract surgery by an obstructive mechanism. And the LLT, means lipid layer thickness, was also significantly thinner after cataract surgery, and people have shown that this is also important. You had to look in this. Meta-analysis reports are there. Worsening the symptoms and signs of dry eye observed more frequently patients with pre-existing MGD. So, and we also know the laser refractive surgery, and there is a complex mechanism is happening in laser refractive surgery because of docking, because of laser, because of 360 or smile, whatever. So, they are also affecting mammalian gland. So, ACRS preoperative OSD algorithm is there for clinical examination in LLPP, look, lift, pull and push. These 4 important clinical examination is, so we actually have forgotten to check the leads because of we are more of cataract focus. So we directly look at the pupil and cataract status of the patient, but you know that the lead is the most important part of our eye. So slit lamp examination, you have to go for lower tear meniscus height, reduced tear leg, mucous strand or debris, slow or no movement of the with the lid movements, and you can also interference fringes of mammalian gland secretion. So, and you can also elicit the toothpaste sign. Right side bottom picture will show that there is toothpaste sign in this. You can use your thumb or a cotton bud to elicit that sign. You can also go for rose bengal, lissamine green and fluorescent stain. And if you see that this is the surface which I cancel for the operation, you see that after doing all the tests, the tests are positive. So you need to treat that patient before doing any cataract or premium IOL surgery. So like coming to the lippy view and lippy flow, lippy view, lippy scan. Lippy scan there is early modification, earlier version, and lippy view 2 is now current version, and lippy flow is their treatment section. So lippy view and lippy flow, initially it was from Tier Sciences, now Johnson & Johnson has no financial interest. There are 2 components of lippy view system. One is functional component, second one is structural component. So in the functional component, we can see the interferometry, lipid layer thickness and blink dynamics. And in the structural component, we can see the infrared mammography with transillumination device. So interferometry, it is just oil in water-like effect. So we can, the lead movement and the thickness and the interference pattern actually calculate the LLT. Normal LLT is 60 nanometer lipid layer thickness. So if you see that the top one is the normal movement, so with the movement is all colored interference pattern, you can look into it. Compared to lower one, when you see this, the movement is sluggish and not so colored like upper one. So the video capturing, you can identify that there is some problem in this lower patient. So height of LLT actually calculated by the software system to know that what is the things are going on. So as I said that normally it is 60 nanometer or more, and also it gives the partial blink ratio. So normally 40% conscious blink, and if it is less than 40%, you have to tell the patient he or she needs conscious blinking training. Whereas the mammography part is direct and dynamic. There are also adaptive transillumination, especially for the lower lid, and dual mode for better contrast for the lower lids. So if you see this in the left side, the gland duct dropout classification, the top one is no dropout, second one is mild gland dropout, third one is moderate, and lowest one is the severe. And in the right hand side, you will see the gland duct dilatation, no dilatation, mild dilatation, moderate dilatation, and severe dilatation. These are almost all clinical. Machine doesn't quantify actually. The other machines have this quantification, but Lippy View 2 system doesn't give any quantification of this, how much percentage of dropout or dilatation it cannot give. summary of reports we get, like this is, you see that Dr. Bashak is here. So average LLT is borderline in one eye and other eye it is less. Partial blink, 100% partial blink in both the eyes. And if you see the glands, the right eye you see the tortuous, irregular glands. Some ducts are also blocked. This right eye and the left eye, you see much less glands. And in the lower lid, there are dropout areas, and I am having MGD, maybe moderate type of MGD that way. So I will show some of the pictures. So you see that this patient had a LLT of 51 and 52 lower. And if you see the lower lid of both eyes, you will see that the gross dropout areas of Meibomian glands. Then this is a child of 8 years old who is surprised to see her gland. This we saw, maybe last January or February, for 2 years effect of online classes. And you see that she is having lower lid lipid layer thickness of less than 40, and lower lid is absolutely, half of the glands are gone. We do not know what will happen when she will be reaching our age. So these are very interesting. Here you see that lower lid and upper lid, both lids drop out area, but there is false high lipid layer thickness. Sometimes patient squeezes their lid just before examination. That time you may find that false lipid layer thickness. And this is also another patient, relatively good gland, but otherwise you see that low LLT, 30 and 25. And again, it could be due to blocked glands, or we are still trying to understand this, what is happening in these eyes, why the machine is not giving. And this patient, 65 years, NS4, asked for multifocal IOL to me. And routinely we are doing for premium IOL surgery, multifocal toric. We are doing lipi view system to see. And you see that in the left eye there is no gland in the lower lid, whereas right eye you can count that there are 2 glands are there. So there is also in the left eye you see the falsely high lipid layer thickness. So a big no to this patient for multifocal IOL. So you have to, this photograph will counsel, very good tool to counsel the patient why we cannot do this thing, multifocal or other PMI. Treatment required for 6 to 12 weeks initially before cataract surgery. If you see any Meibomian gland dysfunction, you give warm compress, sodium bicarbonate, Johnson Bard, etc., etc. Topical cyclosporin has got role, mild steroids, erythromycin ointment, and you have to give doxy or oral azithromycin, lid hygiene, everything you have to go for it. And you see that some patient will be doing good, but you have to go for other procedure-based treatment like mechanical gland extraction we used to do earlier, gland probing, it is difficult, LipiFlow, MevoFlow, Cystine, ILAX, and IPL therapy is there. So I'll be talking LipiFlow only, that LipiFlow has a typical constant temperature between 41 to 43, and it applies pressure with 6 psi and 12-minute treatment cycle. Whole procedure requires around, to fitting and all this connection, around 20 minutes, but actual treatment is 12-minute cycle, and it's effective in patient with MGD. And there are the thermal pulsation, heat from inner aspect, and massaging. 3 things goes together in it. So you see that the vault corneal shield is there, lid warmer is there, and silicone inflation massages. The system is like, you can use it only for once, want to plug in. You see that this video, that this kind of movement happens, and it also simultaneously give heat from the inner surface, give compression. So it is just lid spa, you can call it. but it is very, very important that it needs for some patient of MGD. And people have shown that there are improved meibomian gland structure after doing lippy flow. There are other papers are coming currently because this is a new system for last 5-6 years. So single application of lippy flow treatment before cataract surgery is effective in alleviating blockage of meibomian gland and preventing the decline of TBUT after cataract surgery. Then preoperative management of MGD is effective and optimum in alleviating obstructive MGD and dry eye induced by cataract surgery. And following this is also called thermal pulsation therapy. Actually, the algorithm has been changed. Astigmatism treatment, actually, if you do this treatment, your tear film stability and your final power calculation for multifocal toric may be a little different. So you must follow it. And it is safe and effective after cataract surgery, and also recommend for those whose baseline MGD and prevent development of MGD dry eye for other ocular surgeries also. There are a lot of papers are coming in from 2017 to till date. So it includes mixed and evaporative dry eye patient, routine preoperative investigation in laser vision correction and multifocal IL. In our hospital, it is a routine thing. For IT professional, including teachers, students now, because they are spending time more than 8 hours on digital devices. Postoperative patient, both for cataract and laser vision correction after the contact lens intolerant patient. To educate and explain the prognosis to chronic dry eye patient that we could do something and we may not do something. So to whom do we treat? Understand the goal of therapy, willing to modify the lifestyle. This is one part of the tension. The willing to modify lifestyle is very important. The affordability issue is there. May need repeat treatment every 2 to 3 years. So the most suitable candidate is IT worker or using computer for a long duration, visually demanding work. Refractive surgery patient, premium and older patient who actually has obstructive or MGD, blocked dropout gland. So take-home message is good ocular surface is prerequisite for predictable outcome in cataract and laser vision correction. Dry eye and MGD are quite prevalent in our surgery patient population. Pre-procedure detection and treatment gives the optimal outcome. A good for patient prognosis and selection also. Vector thermal pulsation, that is lippy flow system before the procedure, can modify planning and improve your outcome. Thank you very much for your patience hearing.
Thank you, sir, for such a nice talk. And I think we can take 1 or 2 comments or any questions before we wind up the session. One thing that I would like to comment, we have discussed so many of these investigations. We've discussed ray tracing, we've discussed corneal biomechanics, we have discussed the step source OCT, we've discussed corneal tomography, and we've discussed this lippy view and lippy flow. What they say is trash in is trash out. Make sure that when you're getting readings for any instrument, be it a simple biometry, be it an ultrasound, that your reading is reliable. These are eye patients, many of them, sometimes you will do some study and you'll see a reading and then again, the next reading will be totally different in that patient. We've seen the pentacams and topography maps changing dramatically just because the patient's dry eye was treated. So please keep these things in mind. Machines are very easy to rely on, but we need to have good data which goes into the machine so that it is reliable and we are able to do what is actually good and necessary for the patient. Any other comments before we wind up, sir?
Yes, all the things are not for our purpose or treatment strategy. These are also important. We used to give the print to the patient All cases, like we do not have AIOC SWAP source, but we have Solix. It is quite good, big diameter. And also we had the initial spectrally soft to view ASOCT. But whatever way we are doing it, we giving to the patient and we actually explain to the patient, this is your lesion, we need to do this, we need to excise up to this area, and you will be doing fine. Like your cataract case, you explain that, yes, there is a posterior rupture, you need vitrectomy along with, we may not give in the bag IOL, but we'll be ready with, sulcus fixation, multi-piece IOL, but we'll be prepared before surgery that you have such problem. These are very important for patient education also, all
Correct.
the things.
Correct. With this, I would like to thank the panel for the very and with this session will come to an end. I think the next panelists are ready. I'd like to invite the panel for a photograph before we hand over the stage. Thank you so much.